Hello everybody, my name is Jörg Hausleiter and we're here in London at the PCR London Valves 2023 meeting, and with me are two of my best friends, Rebecca Hahn from New York and Philipp Lurz from Mainz, and we're discussing today what is the role of the right heart in patients with right heart regurgitation, with right heart failure. Now, what is the role of the right heart in our patients? Can you tell us a little bit about what is your feeling about that, Rebecca?
Well, I think learning about anatomy and how the tricuspid valve interacts with the right heart has really taught us a lot about how the right heart function may actually impact the tricuspid regurgitation, because all the cords are attached to the papillae muscles or some directly to the septum. So we know that any kind of abnormal positioning of the papillae muscles, like with right heart dilatation and dysfunction, or septal displacement from either left heart failure or from pulmonary hypertension, can affect the way the leaflets coapt. And so it's intimately, the RV size and function is intimately tied to tricuspid valve function.
We shouldn't forget, when we started with transcatheter interventions to treat tricuspid regurgitation, there was a tremendous risk and fear that we would cause right heart failure in all of these patients. And we discussed it a lot, obviously. And we now know that at least for TEE, for repair, it's anecdotal. It's no clinically relevant problem. Having said that, obviously it could matter also for replacement, maybe even more so. And it might also inform us a little bit on who's doing better after an intervention and who might not do that well, and actually might also inform on the timing of these interventions. So obviously the right heart function is very much linked to the tricuspid valve, there's no doubt.
Absolutely, and you already pointed out that the procedural safety is so important and of course also related to the right heart function. How do we assess the right function best in our patients so that we can predict the outcomes and also select the most appropriate therapy for our patients? So do you want to start first?
I mean, obviously what's almost always done is an assessment of TAPSE, which is more a reflection of the longitudinal contraction of the right ventricle. That gives you already some idea. But what actually the three of us have found is that quite often, especially early in the disease stage, you lose longitudinal contraction, but it sometimes is compensated for by radial contraction of the right ventricle. So in short, if you do only look at TAPSE, you might underestimate RV function, you certainly misjudge RV function, and I think that there is common sense now that you should add something else, more global assessment, whether it's a 3D echo or MR or CT, but something more than TAPSE.
So you talked mainly about transthoracic echocardiography. Becky, you're an expert in transesophageal echocardiography. How do we assess the right ventricular function by TEE, and does it give us an additive value?
I think that because the right heart and tricuspid valve is a near field valve to the chest, it's very close to the sternum, that both TTE and TEE give us a pretty good look at right heart function. And so we'll frequently start with transthoracic and get really good 3D transthoracic imaging, which I know you do as well. And outcomes have been associated with the RV ejection fraction by three-dimensional echo, as well as CMR. So we know even the same number has come up time and time again, which is an EF of 45%, where you start to see reduced outcomes with or without a transcatheter device therapy. And so we do think that the global function, as Philip has said, is a very important thing for us to measure. We don't know if it should be the sole determining factor for whether or not we do a device therapy. And then there are other factors that may also play a role, such as RV-PA coupling.
I was just trying to elucidate on the RV coupling. Philip, what is your take on the RV coupling?
One thing I'd like to add, the problem always is that we would assume that in severe tricuspid regurg, RV function is slightly overestimated. I think we still don't know how to get around that problem and diagnostic dilemma, but for the time being, you should be prepared to expect RV function to be a little bit less, to be impaired as compared to before you treat the tricuspid valve, just given the fact that normally it's overestimated before. And then, as you said, the obviously RV function and TR, but also PA pressure, so it's preload and afterload of the right ventricle, they are linked with each other, there is no doubt. So that has to be put somehow into perspective. And one way to do that is to assess RV to PA coupling. There's actually quite a good body of evidence now to do so, because it's relevant for the prognosis. But what we still haven't understood properly is how much afterload the RV can still cope with. And sometimes when pressures are too high, maybe it might be too high thereafter. But when there are completely low pressures and the RV is not able to generate any pressures anymore, it might also be a bad sign. So just one number informing on yes or no, it's not like that, unfortunately.
It's not that simple. But that brings me to the next question. Now, if we're assessing our right ventricular function, how does this influence our decision making on what kind of therapy we're going to propose to our patients?
Well, I find it's an interesting question, and something that I've learned a little bit from PV loop analysis that may be going one step too far, but I think you had presented a case where you had a PV loop, and what ends up happening is that as you reduce the amount of regurgitation, the volume of the RV definitely goes down, and in doing so, then the stroke volume also goes down. But what we want to see is the stroke volume increasing going forward. And so I think that we need to assess the more TR you reduce, the more you reduce the volume of the RV, the more the stroke volume, total stroke volume, looks like it's going down. So that's going to be the difference between a device that takes away all the tricuspid regurgitation and a device that may only take away most of the tricuspid regurgitation. So you may see worse function, worse stroke volume, total stroke volume, with, for instance, a replacement device that may take away all the TR. But it's something that we don't know whether or not the forward stroke volume is still going to improve.
How do you use it in your practice?
Maybe slightly simplistic, but also practical approach to it is if you think about TEER, then you probably can treat almost every right ventricle, because once you have an RV which is, from a function point of view, that poor, then normally they don't qualify anyway for TEER anymore. With replacement, it's slightly different, because there it seems to be more important to start with a reasonably well-preserved RV function. A proper cutoff value we don't have yet, but certainly the message is, when you think about replacement, assess RV function thoroughly.
Wonderful. So I think we can conclude that first, we have learned over the last 10 years a lot about right ventricular function, that echocardiography is the main diagnostic tool to assess the right ventricular function, and that we're still learning of how to use this information for the therapies we're going to use today to treat our patients with right heart failure. Thank you very much.